If you're a lifter who's dealing with back pain, then chances are you've either been told or think that you have a disc injury and that's the cause of your pain. Now, whether or not that's actually true and what you should do about it if it is true are things that we're going to cover in this video. The overall reason why I want to make this video is because back pain in general is probably the most common things that lifters experience as an injury, and one of the most common things that I help my own clients overcome and get back to training. And with that, there's a lot of good information, a lot of bad information, and just a lot of conflicting information online about what's going on and what you should do. So I wanted to basically put together this video to teach you everything that is important to know about disc injuries as somebody who lifts. So what we're going to cover in this video, or what you can expect, is we're going to first go over the different types of disc injuries, when it's actually a problem, when it's not a disc injury, whether you need an MRI for your back pain or for your disc injury, how to self-assess what's going on for you, and then how to modify your training around your injury and how to implement core training safely and effectively in the presence of back pain or a disc injury. So with that being said, we'll kind of jump right into things. And overall, let me pull up this little tool here. When we're talking about disc injuries, it's first important to kind of go over the anatomy of the disc. So you have this kind of outer portion here called the annulus fibrosus. And that's a pretty thick connective tissue type substance that's actually anchored into the vertebrae above and below that disc, and it holds it firmly in place. And it surrounds something called the nucleus, which is right here, that little inner portion of the disc. And with these different types of disc injuries, it involves the annulus and the nucleus to different degrees. So we have things like disc bulges, disc protrusions, disc herniations, extrusions, and sequestrations. In a disc bulge, let me just change the color here, we have more of like a wider, kind of broad-based movement of that material, which pushes typically to the back and to one side. On the other hand, a protrusion is a little bit more kind of focal of a disc bulge, where it's pushing back into the side, but a little bit more in that direction. And then from there, we have herniations, which is where that nuclear material actually starts to come out of the annulus, and it can compress on the nerve roots in that area, which typically causes that symptoms down the leg, like pain, numbness, tingling, pins, needles. So these are the different types of disc injuries. Even though they're often commonly used interchangeably, they're all basically a part of the same process. Now, the reason why the disc bulges and injuries typically happen in this direction, where they go backwards and to one side, is just due to the anatomy of the spine itself. There's a lot of very strong kind of connective tissue right in the middle of the spinal canal and of the disc, and because of that, it usually pushes backwards into one side. And that's what typically causes the one-sided back pain, one-sided leg symptoms, all these sorts of things. So the next thing to talk about is how common are disc injuries? We kind of know what they are and what's going on, but so many people are told that they have disc injuries, and that may or may not be true. So we have this study by Brinjukji, I think that's how you pronounce their name, et al. In 2015, which is a systematic review that looked at the MRIs of over 1,000 people that had no back pain. And what they were doing is they were ultimately looking for how often or how frequently do we see these different types of changes in the spine and in the discs in people who don't have any pain. And so if you'll see here, we have disc bulges. There's about 30% of people in their 20s have a disc bulge. And then that goes all the way up to 84% of people in their 80s. So you can see it just increases decade after decade of life and becoming more prevalent over time. And the same thing is true with disc protrusions. In the 20s, 29% of people or so have them. In the 30s, 31%. In the 50s, 36%. And it increases to 43% in their 80s. So again, this is really important to know, because these are how often we're seeing these different types of disc injuries or disc issues in people who have completely no pain. And that raises the question of whether or not the changes that are seen on your MRI, if you have an MRI done, are what's responsible for your pain. A lot of these what we typically would think of as disc injuries, like the bulges and herniations and protrusions and all that sort of stuff, in many cases, we now view them as normal age-related changes in the spine that actually aren't causing too much of an issue. And this is ultimately because pain in general, and especially back pain, is very multifactorial. So we have kind of what we call the biopsychosocial model, which is basically just what factors go into pain. So we have bio, psycho, and social. And there are many factors within each of these three components. So in the biological portion, you have things like the actual tissue changes or tissue trauma, like the disc bulges and disc injuries. And then you have psychosocial factors like work stress, life stress, beliefs about pain, prior experiences with pain, what different healthcare providers and other people tell you about your pain. If they tell you that you have the worst back that they've ever seen, that's probably going to influence the pain that you're having. And because of that, all of these factors, there are many, many different factors that ultimately go into this process. So they all kind of combine and either result in you having pain or not having pain, and also influencing the severity of that pain. And this kind of brings up a really good point that your imaging, or what's seen on your X-ray or MRI, does not necessarily determine your destiny or your course of pain and function and being able to do the things that you want to do and lift and train and all that sort of stuff. You can have minimal to no changes on an MRI and have very severe, very limiting back pain. And on the other hand, you can have really significant changes on your MRI, like multi-level disc herniations and stenosis and arthritis, and have minimal to no pain. I've worked with many lifters who've been diagnosed with L5-S1 disc herniations. That's probably the most common level for like a disc injury, just due to the anatomy and kind of mechanics of the spine. And they'll have very similar levels of herniation, similar levels of compression in the nerve root. And based on all these other factors, one person had really severe pain that was basically making them unable to train whatsoever, and the other person was having fairly minimal pain. Like, it was still an issue, but they're still able to train a little bit. They're still able to do their daily activities, and it wasn't like ruining their life as much as it was the other person. And again, that's just because so many things besides what's structurally going on in the disc or in your spine determine if you're going to have pain. And if you do, the level of the pain, the severity of the pain, how much it impacts you, all those sorts of things. So if you've been diagnosed, like you had an MRI because you have been having back pain, you go to a physician, you go through the MRI, and you find that you do have disc bulges, protrusions, herniations, whatever the case is. That doesn't necessarily mean that, one, that's the true cause of your pain. It very well may just be what we call an incidental finding, where it was there before you ever had pain, and we just never had a picture of your spine before. And because you're now having pain, they took the picture, they took the MRI of your spine, and they found it. So it is possible that the disc injury has just been there and not causing issues, and now it's just been found. On the other hand, it can be causing or contributing to what you're experiencing, but that doesn't mean that you're going to be that way forever, because like we're going to talk about next, discs can absolutely heal, contrary to what a lot of people have been told. So a lot of people have been told by doctors or physical therapists or chiropractors or whoever they see, even sometimes like what they read on the internet or hear from friends, that once a disc injury happens, once that herniation happens, that material is kind of out of the disc, then that's it. Like, you're going to be in pain, you're going to have to deal with it for the rest of your life, and it just is what it is. And a lot of people think that discs don't have a capacity to heal, and that's just simply not true. Discs are like pretty much any other tissue in our body, in that they do have a good capacity to heal, provided the right circumstances. Like, you modify the things that are aggravating it or causing the injury to happen in the first place, and you give it the time and kind of necessary rehab strategies and treatment strategies to do so. And this, that should be Zhao. This study by Zhao et al. In 2002 is a great example of that. This is a meta-analysis that looked at the healing rates of different types of disc injuries. So what you'll see here is that overall, so they talk about disc resorption, which is basically when you have that disc herniation, that like nuclear material leaks out of that annulus fibrosus and it pushes out of that initial kind of disc space. And what they found is that overall, when you look at the different types of disc herniations and disc injuries, on average, about 70-71% of them go through what they call disc resorption, which is when that material kind of recedes back into the middle of the disc. It leaves that space where it's now outside the disc where it can be causing issues. And the really interesting thing is that when you actually look at the different types of disc injuries, the larger and more severe the actual initial injury, the more likely it is to go through that resorption process, possibly because it causes your body to mount a larger autoimmune reaction or autoimmune response, or just an immune response in general, and help repair that disc. So when you look here, disc sequestration is when that material goes out and that nuclear material kind of falls off like the inside of the annulus. And about 88% of those went through disc resorption. Meanwhile, for an extrusion, which is kind of a less severe type of disc injury, now we're down to 67% go through spontaneous resorption. And then for disc protrusion, about 37-38%, and then 13% for disc bulge, etc. So it shows that all types of disc injuries can heal, and the larger the actual injury, the more likely it is to have that disc material resorb and like structurally heal. So that's really good news because it shows you that from a structural standpoint, things can absolutely get better and actually heal. The other thing to realize is that when we're talking about healing and getting over back pain, what is happening structurally with the disc is only one part of the puzzle. Again, you can have a very large disc herniation or disc injury and not have any pain or limitation. So even if you have that disc injury and that nuclear material doesn't resorb, it doesn't go back into the middle, and the disc doesn't necessarily heal from a structural standpoint, that doesn't mean that you can't resolve your pain, resolve your symptoms, and get back to the stuff that you want to do without any pain or limitation, because that structural component is, again, only part of the puzzle. So you can have an MRI right now, have a very noticeable disc herniation, have a lot of pain, go through a good rehab process, have less and less pain over time, slowly get back to lifting that you want to do, and be healed for all intents and purposes. And then you could have an MRI down the road 6-7 months, a year later, and the disc could look the exact same. But that doesn't mean that you haven't healed. It just means that that structural component is only one piece of the puzzle, and your body has been able to adapt to what's going on and get you back to what you want to be doing. So just to recap that, disc injuries are like one of the most common things that we are told is causing back pain. Whether or not that's actually true, it's up for debate in a lot of people. But there are different types of disc injuries. Discs have a very good ability to heal, and you can have very minimal pain, if not any pain, with noticeable disc herniations and vice versa. So that structural component, again, is only one piece of the puzzle. Now, when we're actually talking about true symptomatic disc injuries, these typically follow a fairly classical like symptom profile. So usually what we'll see is that the leg pain or the leg symptoms is worse than the back pain. So if you have a true disc injury that's actually causing or very much contributing to what you're experiencing, you're probably going to have a lot more leg pain or leg symptoms than you do back pain, which may be counterintuitive, but that's just the nature of the injury itself. You may also very well have, again, pain, numbness, tingling that radiates down the leg. Coughing, sneezing, and bracing may increase your symptoms because when you do that, it causes an increase in the pressure within the spinal canal, and that can further exacerbate things. And flexion, so bending forwards, is usually a little bit more provocative than extension. For some people with true symptomatic disc injuries, extension, so bending backwards, can flare up their symptoms more. It is just a lot more common that flexion is the predominant thing that really flares up their symptoms. Now, some people with these types of true symptomatic disc injuries may also notice that they have weakness in the leg. And this follows a specific pattern of whatever nerve roots are involved in that disc injury. So very often things like a calf raise test or walking on your heels might be limited on that side of the body where that disc injury is. Now, when we're talking about back pain in general and disc injuries for sure, there are what we like to call red flag signs and symptoms. And these are basically signs or symptoms that indicate that something a lot more serious or a lot more of a medical emergency is going on. So these would be things like bowel and bladder incontinence and saddle anesthesia, which means that we might have something called cauda equina syndrome, rapid progressive weakness of the legs. So if you notice some weakness initially and then it's quickly getting worse and worse, that's also a red flag. And then fever, unexpected weight loss, history of cancer, history of trauma. These can indicate that something like an infection of the spinal column is happening, a tumor or a cancer, or a major trauma can indicate like a fracture, that sort of thing. All of these things, these red flag signs or symptoms, if those are there, then those can strongly indicate that there is more of a medical emergency going on. And that requires a very different type of treatment and management approach than back pain or leg pain without these signs or symptoms. And that leads us to our next topic, which is about MRIs and back pain or disc injuries. Now, a lot of lifters that I've talked to believe that they need to have an MRI done to know exactly what's going on in their backs so they can know what to do and how to fix it. And unfortunately, or maybe fortunately, depending on how you look at it, it really isn't that cut and dry. In most cases, an MRI is unnecessary if you're having back pain or a suspected disc injury. And in many cases, it can cause harms by getting an MRI early when you don't need one. Now, there are certain situations in which an MRI is warranted, which we'll go through. But again, if you're just having back pain, even if it's fairly severe, you're having pain, numbness, tingling down the legs, that sort of thing, then if those are just the symptoms that you have and you're not experiencing those other red flag signs or symptoms, it's actually recommended that you don't get an MRI right away because it can have unwanted effects, which we'll talk about in a little bit. However, you should absolutely get an MRI if any of the following are present. You're having progressive neurologic deficits, so like worsening weakness, worsening numbness and tingling down the legs. You have severe unrelenting pain that isn't improving. If you're very strongly considering injections or surgery, because that's going to involve the physical structure of the spine and doing treatment methods that impact that structure, and if you have any red flag signs or symptoms. If any of those are present, then getting an MRI is warranted to either rule in or rule out any of those other more medical emergencies that we talked about, or two, plan for whatever invasive treatment strategy you're going to be going through, whether it's injections or surgery. Now, there are several good reasons why you shouldn't get an MRI right away if you don't have those specific situations or symptoms kind of going on. And that is, one, many of the things that you're probably going to see in your MRI are unrelated to the pain and limitations that you're having. Again, we talked about earlier how a lot of disc bulges and herniations and other injuries are present very frequently in people who don't have any pain or limitation. It's even been shown that they have them pretty much just as frequently as people who do have pain and actual like disc injuries. So because of that, if the chances are if you're over like the age of 15, then you're probably going to find something on that MRI. And there's always a question of whether or not it's actually what's causing your injury or really strongly contributing to it, or if it's just something that has been there for a long time, not causing any issues, but now because we see it on the image, we think it's an issue, and you have additional more invasive treatment strategies, like you get recommended injections or surgery, which again are invasive. They carry their own risks, even if they're relatively small. But if you don't need to go through an invasive procedure and run those risks, then it's usually best that you don't. And on top of that, it's also been shown that having an MRI early on, it incurs typically larger expenses related to healthcare for people who have back pain. There was one study that looked at specifically this and found that I think on average it was at least $1,000, if not more, that people spend out of pocket with the fact that they have an MRI, just due to the cost of the MRI and due to the cost of other like intensive surgical procedures or invasive procedures and all this sort of stuff. And obviously, like when you get an MRI report and you see that you have multiple disc bulges or herniations, or you have arthritis or stenosis or all these things that are very likely to be found on an MRI, whether or not they're causing an issue, that's scary. That can cause a lot of fear and anxiety for anybody, whether or not you know about this stuff in great detail and you're a healthcare provider, or if you're just a lifter who's been experiencing back pain and you get the MRI because that's what you were told you should do. And that fear and anxiety can cause further issues with the limitations that you feel while training and doing daily activities. It can actually make your pain worse and your disability worse. And ultimately, at the end of the day, unless you have something that is a medical emergency, you're undergoing injections or surgery, getting an MRI is not needed to come up with a very solid treatment plan. When we go through an assessment for our clients who are dealing with back pain or disc injuries, the specific thing that's going on with their back from like a structural standpoint is not what determines how we program for them and what they do to solve their pain. Really, what determines that is where they are currently. So what triggers their pain, what their limitations or deficits in flexibility and strength and stability are, what their overall goals are. All these things are actually what determine the treatment plan, instead of just the picture of the spine. Because again, two lifters can have very similar, if not the exact same findings on MRI, and need very different treatment plans based upon what causes their pain, what their goals are, all that sort of stuff. I'm not going to take a competitive strongman with an L5-S1 disc herniation and treat them just the same as I would a recreational powerlifter who has the same injury or issue. I'm going to treat them very differently based upon their specific situations. So next, we're actually going to talk about what you can do or what you should do when you're dealing with this type of injury or issue. So obviously, like we just talked about, how to best treat this is going to come down to your specific situation and limitations and goals. But the following strategies are things that we do with pretty much all of our patients with this type of back pain and back pain in general, and they can apply to pretty much everybody. And the first is centralization and peripheralization. So this is just what we call a repeated motions assessment. So centralization is when we have somebody that's having pain that goes down the leg, pain, numbness, tingling, any of those symptoms. And you implement a movement or a position that causes that pain to start, or those symptoms to start coming out of the leg. So let's say initially is going from my buttock all the way down to my calf like that. Now we take them through an assessment or a movement kind of repeated motions test. And instead of going all the way down to the calf, it's only going down to my thigh. Because it's starting to come up out of the leg, that means it's moving in the right direction. However, if before this assessment it was just going down to about the knee, and then we did a motion, whether it's flexion or extension or whatever the case is, and it's now going further down the leg, we call that peripheralization. And that means that things are getting more irritated, and we want to avoid that because the nerve is basically just getting more pissed off. So the way that we do that is by taking the person through an actual repeated motions assessment. So we see how these different movements affect the location and intensity of the person's symptoms, and we use that to guide our treatment process and rehab drills. So the main movements are flexion, rounding forward, extension, bending backwards, and then side bending or side gliding to either side. So how we do this in real time is we'll have the person just standing in place, kind of taking note of how far down their symptoms are going and how intense they are. And then from there, we'll have the person do about 5 to 10 repetitions of each of these 4 movements. And then after the 5 or 10 reps of each of those movements, we see what change, if any, there is to the location and the intensity of the symptoms. So if we're doing flexion, we're doing 10 reps. And throughout that process, before the pain was only going down to mid-thigh. And then they did 10 reps. They stand back up, and now it's going down to their calf. That means that it peripheralized, and flexion is the movement or position that aggravates their symptoms. On the other hand, if they're having those symptoms down to the calf, and then they do 5 or 10 reps of extension or bending backwards, and then they stand back up again, and the symptoms are now only down to mid-thigh instead of down to like the knee or calf, that means the symptoms are centralizing, which means that extension is the movement that they prefer, and that's how we're going to dose that movement throughout the day. So we try to find the movement out of these 4 movements that causes those leg symptoms to centralize, and we have the person repeat that movement fairly often throughout the day. Usually, the more often we repeat that movement or kind of dose it in throughout the day, the better they do, because it'll centralize the pain and the symptoms a bit more quickly. So we'll usually recommend that people do 1 to 3 sets of 10 several times a day, up to hourly if need be. And that's kind of how we use that repeated motion strategy to get a good understanding of what overall movement strategy they respond well to. As a general rule of thumb, most people with true symptomatic disc injuries are going to, let me see here. All right. Flexion will usually peripheralize your symptoms or make them go further down the leg, and therefore we kind of want to avoid that. On the other hand, extension generally centralizes symptoms or gets them up out of the leg, and that's usually the movement that we want to do throughout the day. And then side bending and side gliding, kind of hit or miss. For a lot of people, side bending to the side of their pain, so if they have left-sided back and leg pain, side bending to that side generally kind of makes it worse or peripheralizes it, but that's very individual specific. So that's the overall kind of pattern of what to expect with the repeated motions assessment. But whenever you're having this sort of pain that's radiating down the leg, you should actually do the assessment on yourself to find what your specific body tolerates and doesn't tolerate, and then use that to guide the movements that you're doing throughout the day. If extension centralizes things, dose in some extension through standing back bends or prone press-ups. If flexion centralizes your symptoms, then dose that throughout the day through some like single or double knees to chest, or even some like Jefferson curl or standing flexion type activities. Now, next is how to actually modify training around a disc injury, because a lot of lifters are told that if they're dealing with back pain or a disc injury, they have to stop squatting, they have to stop deadlifting, they can't do cleans or snatches or any of the other barbell training that we love doing. And that really sucks. None of us want to hear that. And honestly, it's really not necessary. In order to like train around injury, you can do that very safely. You just need to modify the training accordingly to get your symptoms down to a minimal to no level, and then slowly build it back up. And that's the whole calm it down and build it back up approach. That is 80% plus of what makes an effective rehab strategy for any type of injury, whether it's a low back disc injury or a shoulder injury or knee pain. You basically have to modify the training to calm that initial injury down, and then slowly build back up to your regular training so that your body can adapt to it and build up the tolerance to handle the type of training that you want to do. A lot of lifters fall into this trap where they have an injury, they just avoid training altogether or avoid the movements that cause any level of symptoms. They may implement a very easy kind of low-level rehab plan. And if they do that for enough time, they generally start to feel better because they're not stressing the area. But then what they'll do is they'll just jump right back to that type of training that kind of pissed off their injury to begin with, and just starts this vicious cycle where things just get flared up again, so they rest some more, feel a little bit better, try to get back to training, flare it up again, and so on and so forth. So instead, what you're supposed to do, or what we have our clients do, is modify things like the intensity, the volume, the range of motion, the tempo, and the variation or like type of exercise that you're doing. And there are several different ways to do this for each of these kind of categories. So we'll kind of go through them one by one. So first, when it comes to intensity is basically just how hard the exercise is. And that can be the amount of weight on the bar, and it can also, which is what we call external intensity, or percent one rep max, and it can also be internal intensity, which is how hard that set feels to you. And that's usually measured by RPE or reps in reserve. And a good rule for modifying intensity around an injury, especially back pain, is using the rule of 10. And this is basically if you take your level of pain from 0 to 10, 0 being no pain, 10 being the worst possible pain imaginable, and then you add that to the RPE that you choose that should equal 10. So let's say you have 8 out of 10 pain. You want this to equal 10, so your RPE should be a 2. On the other hand, if you have 3 out of 10, it still needs to equal 10. So this time you can use an RPE of 7. It is basically just a good way to modify your intensity around the pain. Basically, the more severe the pain is, the lower the RPE or the lower the intensity you should train with. The less severe the pain is, the higher the intensity or the higher the RPE can be. This is not a hard and fast rule. You can absolutely use different intensity metrics, whether it's RPE or RIR, to guide your training. This is just a very kind of straightforward and easy to implement heuristic that can work well, especially if you're just trying to start getting back into training with this sort of injury. Next is just volume, which is basically how much exercise you're doing, especially ones that stress that injured area. So the number of sets of squats, hinges, clean snatches, etc. that you're doing in a given session or in a given week. A general rule of thumb, if let's say back squats or deadlifts have been really flaring you back up and you want to keep on training, you can modify intensity or some of these other metrics, but also reduce the volume by 1 or 2 working sets. That's a good way to just bring the overall stress of that training session down and the overall stress on your back down, while still allowing you to train and do the type of stuff that you want to be doing in the gym. Next is range of motion. Forgot to highlight volume there first. Next is range of motion, which is just the positions and the range that you move through during the lifts. For things like squats and deadlifts, usually the very bottom of the movement is typically the worst. The leverages there kind of make you stress your back the most, just due to your back position. And similar things for cleans and snatches. Pulling from the floor is usually the most aggravating, as well as catching in a full squat. So for squatting, you can do box or pin squats where you go through partial range of motion. For deadlifts, you can do block pulls or rack pulls. And then for cleans and snatches, you can start from the hang or start from blocks and catch in either muscle position to really limit range of motion, catch in the power position to limit it a little bit less, and then work your way back. And the overall goal of this isn't just to limit the range of motion and keep it there forever. The goal is to find a range of motion that you can relatively comfortably train and progress over time back to full range. So for squatting, for example, I'll often start my clients with box or pin squats where they stay relatively above parallel. Then after they do that for a little while and they're having less pain and they're feeling more confident in the back, we'll slowly bring that range of motion or that depth rather down. So maybe now they're doing box or pin squats to parallel. And then if they like squat to full depth, typically then we work to full depth from there. So just modifying it initially and then gradually increasing back to the regular type of movement that they're doing is how to like actually modify around the injury without just giving up your training or just pushing through it and ignoring it and flaring things up more. Next is tempo, which is just the speed at which you're doing certain parts of the movement. It's usually written in this kind of 3-digit format here, where the first number is the duration or the length of the eccentric. The second number is the duration of the pause, typically at the bottom of the movement, except for deadlifting. And then the third digit is the speed or duration of the concentric or the lifting phase. So 303 squat would be 3 seconds on the way down, no pause, 3 seconds on the way up. A 530 squat would be 5 seconds on the way down, a 3-second pause, and then just a regular speed concentric. Deadlifting is a little bit different because you don't really pause at the bottom because you're on the floor and that's where the movement begins. So a 530 deadlift would be something where you lift to just below the knees, pause there for 3 seconds, finish the lift to lockout, and then lower over a 5-second eccentric. So how we'll often modify tempo around an injury like this is first start with a tempo like the 303 tempo where you're having the person do slow eccentrics and slow concentrics because that's going to limit the weight the most. And then we can move to something like a 530 where you have a slow eccentric and a pause, but a regular speed concentric because you'll be able to lift a little bit heavier. And then finally you can just move to only slow eccentrics or only only pauses, because that will again allow you to use a little bit heavier loading for any given rep range. And then last is the variation, which is just the style of whatever movement that you're doing. So for squatting, this is something like a goblet squat versus a Zercher squat versus a front squat versus a back squat. For deadlifting, this is like a trap bar versus a sumo versus a conventional deadlift. Each of these variations puts you in different positions and stresses the back more or less, so you can use that to systematically change how you're doing that movement to limit the loading on your back and slowly progress it over time. So we'll often have our clients move through this kind of progression where they start with a squat that's much more upright, like a Zercher or a goblet squat, and then move to a front squat, and then maybe a high bar back squat, and then maybe a low bar back squat, and similar with the deadlifting. And then for things like other movements such as rowing variations, bent over rows typically would flare up somebody's back pain. So instead of that, we might move them to a machine row or some other chest support row variation, or just another way to train that movement without loading the back as we're trying to get it under control. So that's how you can modify these different variables around back pain and disc injury. And kind of like the big key to this is finding one or more of those variations or variables to modify and doing it in a way that you can train with minimal to no symptoms. I always tell my clients that the goal isn't necessarily to have there be zero pain at all times during training and during rehab work. We are okay with a certain level of pain because that will ensure that we're training sufficiently hard to make progress, but not doing so much that we're just really aggravating things more and prolonging the rehab experience. And I like to use kind of this traffic light system. And that's basically just a really nice guide to how intense the exercise should be. So pain of 3 to 4 out of 10 or less is basically our green light. With that amount of pain, we know that we're really probably not flaring anything up. That's kind of our safe range where we can absolutely keep on training and progressing within that range. A 5 to 6 out of 10 is kind of our yellow light. We're not going to immediately modify further or just kind of push through. We're going to basically see how long that lasts. If they have a 5 or 6 out of 10 pain, but it goes away right away or like within a couple of minutes or hours after that training session is done, then we're not going to further modify, but we're also not going to progress until it starts to get down into that green light range. On the other hand, if they have a 5 or 6 out of 10 pain and it stays flared up for a day or more, then I would want to pull things back further to calm things down a little bit better. And then pain of 7 plus out of 10 is definitely our red light. We want to pull things back a bit more to get it under control, because if we keep on training with that level of symptoms, then we're likely just going to continue to aggravate things and make them a little bit worse in the long run. Now, one of the most common treatment strategies, especially if you've gone through physical therapy, is to do core training for a back injury or a disc injury. And core training is an interesting topic because it's not needed to overcome this sort of injury, but it can be very useful. A lot of people think that back pain and disc injuries happen because your core is too weak and it can't stabilize your spine. And core strength or core endurance can be a component to this. But it's not just as easy as lack of core strength equals back pain or disc injury. That's not how it happens. That being said, direct core training can still be very beneficial because it does improve the capacity of the spine, the capacity of the muscles around the spine, and it builds a lot of confidence in your back as you progressively train harder. That being said, a lot of the core work that lifters do or are told to do for back injuries is fairly ineffective. It's usually too low level, too easy, doesn't progress enough, and doesn't like truly prepare them to get back to the lifting that they want to be doing. And because of that, gives them kind of a false sense of confidence and will often result in re-injury kind of down the road as they try to get back to heavier squats or deadlifts or cleans. So I first kind of want to go over the anatomy and function of the core a little bit, and then how we actually go about implementing and progressing core work when working with our clients with back pain. So overall, I'm not going to get into all the nuances of the deep core musculature or anything like that. I'm mainly going to focus on the rectus abdominis, which is the six-pack muscles, the obliques, both the internal and external, and then the paraspinals, which are the kind of big muscles along either side of the spine that you can see from the back. So the rectus abdominis, and it's more to note that all these muscles can both resist or prevent movement, so think isometric training, or they can cause movement of the spine. And a lot of people are told to just do isometric training, and those can be very valuable exercises. I use them a lot with my own clients, but that's not the be-all, end-all of core training for back pain. So again, the rectus abdominis is the six-pack kind of muscle group, and more or less they cause spine flexion, so they cause you to round forward, and they can resist or control spine extension, which is arching backwards. The obliques, both internal and external, mainly cause and resist rotation and side bending. The obliques kind of have overlapping fibers between the internal and external obliques on one side. So during a movement, the external obliques of one side will work with the internal obliques of the other, which is why I kind of just lump them together into the obliques because of the big overlapping function. And then lastly is the paraspinals, which mainly cause extension or for you to arch your back, and they resist or control flexion, which is that rounding forward. So those are basically the functions of the core and the muscles of the core. Now, when it comes to training, you can do isometric work where you are preventing your spine from moving against some form of resistance. That can be your body weight, dumbbells, kettlebells, bands, cables, whatever the case is. And then there's dynamic core training, which is where you are actively moving your spine against resistance. When it comes to isometric and dynamic, you can do them into flexion, extension, rotation, or side bending. And when I program core for my own clients, I usually like to have one or two movements for each of those kind of categories, and then program and progress those over time. So just to give you a small list of different types of drills, we'll go for flexion first, and then extension, and then rotation and side bending. So for flexion, isometric exercises are things like dead bugs and just regular planks, and dynamic variations are different crunch variations. So GHD crunch, machine crunch, reverse crunch, cable crunch, all of these are for the flexion kind of component of the core. For extension, isometric variations are things like Sorensen holds and bird dogs, and dynamic variations are things like GHD or 45-degree back extensions, as well as different variations of loaded Jefferson curls. For rotation, isometric exercises for that are things like pallet folds. Those are probably the most common. And dynamic variations are things like half kneeling cable rotations, half kneeling cable chops, band rotations, all those sorts of things. And for side bending or lateral flexion, you can do side planks and suitcase carries for isometric work. And then for dynamic work, you can do things like loaded side bends. You can do them standing with a dumbbell. You can do them on a GHD or on a 45-degree extension. Those are my favorite ways to train those different movements. And just like any other form of training, how you implement and progress core training is basically the same. You start with volumes and intensities that you can handle. So if you're dealing with back pain, you're going to want to start fairly low volume and low intensity because you probably can't handle a lot of direct core work. And then you want to progress that over time. So starting with lower level isometric drills, moving to higher level isometrics, And then from there, moving to dynamic exercises at slow speeds, and then dynamic exercises at high speeds, and then adding load over time is how you want to address the core. And the nuances of how you actually program it also depend upon what your overall goals are. If you compete or train in powerlifting that has the demands of a lot more very short, very high intensity efforts, you're obviously competing in the squat, bench, deadlift, 1 rep max. Those are short duration events that have very high force output. And if you want your back to be able to tolerate that type of training, then you need to eventually mimic that in your direct core work. So progressing to very high effort at either short duration holds for isometrics or low rep sets will adequately prepare you to get to that. On the other hand, if you do CrossFit training, you're going to have a lot more of a mix of how you need to train your core, because you do have periods of time where you have very short duration, high effort demands like max effort snatches and deadlifts and cleans and whatever the case is. And you're also going to have times where you have to have a lot of lower level, more endurance type performance of your back, in which case you should also mix in a good amount of lower level, lower intensity isometrics or lower intensity dynamic exercises where you're doing higher reps, higher volumes. So you need to match how you do your direct core training to the actual demands of your other type of training in order for it to have the best carryover. And that's where a lot of lifters are kind of led astray by the rehab work or the core work that they're given by their physical therapist or chiro or whatever the case is. They're usually just told to do bodyweight planks, dead bugs, bird dogs, which again can be a very good place to start. That's just, it can't be the end of the road for your core training, because the amount of strength and endurance adaptations that you can get from those exercises is pretty limited if you only ever do them with body weight. You need to get the stuff more aggressive over time. And I'll link a little downloadable link to a 12-week core and low back program that I made. That way you can kind of see for yourself how we actually implement this and progress it in real time. Again, it's a templated program, so it's not going to be unique to you and your injury and your situation, but it will show you how I tend to kind of program this stuff and progress it over time. And the very last thing to talk about is restoring flexion tolerance. And that is basically restoring the ability to handle that bent forward position or moving through that bent forward range of motion of your back. And this is important because obviously life and training happen outside of a neutral spine position. Doing stuff around the house and with your kids or just day-to-day stuff, you're not always going to be in a neutral spine position. And similarly with your lifting, when you're squatting and deadlifting and doing kettlebell swings and cleans and all this stuff, even if it looks like your back is staying completely neutral, it's been shown that your spine is actually moving through some fairly good range of motion. So you need to develop the ability of your back to handle that type of demand outside of neutral spine. And for most people with true symptomatic disc injuries, flexion is the most limited movement and the most aggravating movement. So we kind of save this for last, because once you get things to calm down, that's when you really want to start attacking that flexion tolerance. And a sample progression that I use takes you from cat camels to banded cat camels to seated Jefferson curls to wall Jefferson curls to standing Jefferson curls, and then to more advanced Jefferson curl variations like Zurcher's Jefferson curls with rotations, deficit Jefferson curls. And I really like this progression because it takes you from positions and loads that are not nearly as stressful on the back. So quadruped on hands and knees with just body weight in the band or in the regular cat camel, and it slowly progresses you to standing against resistance, because that's what actually gradually and methodically builds back that tolerance so that you can make sure that your back can handle getting into that position in the future, because it's needed for daily life and for training, without really aggravating right now and just prolonging things. So this is a really good kind of summary of honestly a lot of the stuff that we go over with our own clients who have back pain and disc injuries. And this is kind of like the really important stuff to know as a lifter if you have a disc injury or if you think you may have a disc injury. Just as a quick recap, Disc injuries are a very commonly cited cause of back pain, but they're definitely not a death sentence. Disc injuries can heal just like pretty much any other injury, and they do have a good rate of healing. You probably don't need an MRI if you're going through back pain unless you have those specific red flag signs or symptoms, or you're really strongly considering injections or surgery. And then when it comes to actually addressing and overcoming disc injuries, you need an approach and a plan that's unique to you, because your situation is going to be different than other people's, and it needs to be as honed in on your pain triggers and limitations and goals as possible. But the overall kind of strategies that are really effective are determining if you have that directional preference with the repeated motions assessment. So finding that if you do find a movement that centralizes your symptoms, dose it in throughout the day. Modify your training accordingly to your pain. So keep doing the movements that have typically been aggravating, but find ways to modify the range of motion and volume and tempo and all that other stuff so that you can train it with minimal to no symptoms and then progress it over time. Implement targeted and thoughtful and progressive core work where you're not just doing bird dogs and dead bugs for months on end, but you can start there and slowly progress over time. And then eventually restoring the capacity to handle the positions and the movements that are most aggravating for your back. If you have a true disc injury, again, it's probably going to be flexion, but this goes along with extension, rotation, side bending, depending upon what your pain trigger is. So yeah, this is kind of, like I said, a big overview of the topic. I really hope it was helpful. And if this is something that you're struggling with and maybe you're overwhelmed or you're just unsure what to do, or you just want more guidance and an actual individualized approach to this, then click the link below and request a phone consultation with me, and I'll see if we can help you out. And if I'm really confident that we can, then we'll walk through exactly what that plan will look like. All right, bye.